Hi to those who've just joined us. We're just going to wait a couple more minutes before we get started. Okay, well, it's a couple minutes after the hour, so we'll get going. Hi, everyone, and welcome. My name is Fiona Lewis, and I'm the Patient Support Liaison for AMAC. I'm pleased to welcome you to this webinar this evening. As you may know, AMAC is a leading funder of research into bone marrow failure diseases in Canada, and I invite you to visit our website to find out more about our services across the country. Your phone line will be muted during today's presentation, but you can type any questions you have into the Q&A feature, which you'll see at the bottom of your screen if you hover your mouse there. There'll probably be time for us also to unmute the lines at the end of the presentation, so you can just ask your question that way as well. Please note that today's webinar will be recorded and should be posted on our website within the next week or so. So I'm pleased to introduce Dr. Pastore to present today's webinar entitled Transitioning from Pediatric to Adult Care in Inherited Bone Marrow Failure Syndromes. Dr. Yves Pastore is Associate Professor in Pediatrics at the University of Montreal. Of Swiss origin, he completed his residency at the University Hospital of Geneva and then a fellowship program at Texas Children's Hospital in Houston. He joined the Hematology Oncology Service of the Pediatric Department of Chu Sainte-Justine in Montreal in 2010. He has a strong interest in hematological diseases. He is currently the head of the Inherited Marrow Failure Program and developed a dedicated clinic for patients with Shwachman-Diamond syndromes and other inherited marrow failures. He is dedicated to improving quality of care in strong partnership with families and patients. So with that, I'd like to thank you, Dr. Pastore, for being with us today, and I'll turn it over to you to start the webinar.
Thank you, Cindy, for really the invitation. It's a pleasure being with you. Really apologize as we were supposed to get this the meeting going in May, and for some unforeseen personal reasons, I couldn't make it. So I'm really glad that we finally are here, and really happy to discuss with you on the transition from pediatric to adult care. The presentation was actually already given in the spring, I believe in April, during the annual symposium that Eagle Drawer from Sick Kids is organizing to share knowledge and discuss different topics around inherited marrow failures. So I'm really happy to share with you what we presented at that times, and that the presentation also reflect on where we are at on our reflection on what should be done and what we would like to do to improve transition from pediatric to adult care. So it's clear that if we think of transitioning from pediatric to adults, it's certainly not a simple jump from one place to another. It's far more complex than this. So one of the first questions before I started, organizing my presentation, I had first reflex, as we always most often do have when we're asking questions as physicians, and one of the question is it really an unmet need? So first of all, with the discussions that we had and started already in 2021, it was absolutely clear that there's a great need and recognition of the importance of guiding the transition of care for patients with marrow failure. And there was a large interest on that early discussion that took place in 2021 and continued in April this year at the annual symposium, as I mentioned. And it's clear that if I talk to my patients, the answer is clearly yes, there is an absolutely need. And what is really striking is, when I look on the literature, when I want to know what has been described and what has been learned on the transition of care from pediatric to adult, specifically for a patient with inherited marrow failure, I was kind of shocked to see that there is a lack of knowledge and lack of scientific literature on that process. So definitely there is a clear need to improve our knowledge, generally speaking, on the transitioning from pediatric to adults. There is a need also to improve the knowledge of inherited marrow failures among healthcare providers in general. It's definitely striking that even among specialists, sometimes inherited marrow failures are not necessarily well known. And it's clear that if you're talking with general practitioners, family physician, some physicians may know a bit about it, but there is a certain lack of knowledge. So we think that there is also a need to improve awareness of inherited marrow failures and improve the quality of care and following up of patients with inherited marrow failures. One of the difficulty that we're facing is that as it has often been observed in diseases that are diagnosed early during childhood, it's clear that often patients that grow up into adulthood go into a system where many of those diseases are not necessarily also well known or also poorly recognized. There is definitely a growing interest in the adult care, and there is an increase in the quality of care, but that also goes along. And if we think, for example, of patients with severe congenital neutropenia, many patients decades ago may not reach the adulthood, and adult providers may not necessarily see those patients, not only because those are rare diseases, but also because some patients may not reach, unfortunately, adulthood. There is also a fear that is linked to inherited marrow failures. As you know, there are long-term risks with those different type of disease, and it reach also different aspects. For example, teenagers that I'm following start to get really a lot of questions around the aspects of sexuality, reproductive health. They questions a lot of, what is going to happen if I want to get kids? Well, my kids going to have it. So there are a lot of questions that surrounds inherited marrow failures. When I think of transitioning from pediatrics to adult care, here is what I do hear. What do the patients say? Parents says, it is difficult to leave children hospitals as we have a sense of leaving a family. Or, I'm anxious for my child as adult provider in my region do not know much of my child's conditions. So those are illustration of the lack of knowledge and the difficulty of having providers that do have specific knowledge on rare diseases. When I discuss with adolescents and young adults, here are the concerns I do here. And if I go into adult hospitals, will there be a nurse or provider who also know my condition well? They also say, I'm not worried yet because I'm doing fine, doc, you know? Some of them start to also question on what they should do in life. And they ask specific questions like, do you think it is okay if I choose that type of job or that type of orientation? And so they have those questions that are extremely important just to guide them. And those are also important questions when we think of transitioning from pediatric to adult care. Transitioning from pediatric to adult care for patients with inherited marrow failures is definitely complex. While we certainly know, and that's my bias as hematologist, we know that there are common hematological risks. Inherited marrow failures, for many of them, may not be only associated with such hematological risk, but they might be also risk for other organ dysfunctions. And that, for most of the inherited marrow failures, that requires a multidisciplinary care approach. So that's part of the complexity from transitioning from pediatric to adult care for patients with inherited marrow failures. It's one thing to transition for one specialist. I'll be interested to ensure that my patients are being followed by an adult hematologist. But for some conditions, let's say, for example, patients with Fanconi anemia, they may be at other risk and they need to have ENT follow-up. They need to get gastroenterology follow-up. Woman needs to get a good gynecologist follow-up, etc. And that's the same thing for other type of disease, for Schwachman-Diamond syndromes, for example, where nutrition aspects, gastroenterological aspects are also crucially important. And you need to organize the following up not only for one specialty, but just to make sure that there will be a good follow-up care with the same multidisciplinary approach. So that's definitely part of the complexity. Ideally, I'd like to get a transition that also involve a family physician. And the idea there is that a family physician, if we provide them with good knowledge of the disease, can somehow orchestrate the following up with all the specialists that are needed. If I was mentioning with you that there was not much literature around this, and this is one thing that I've done. I look on transition of care, transition from pediatric to adult, and inherited marrow failures. Our search engine that we usually use is PubMed, and that lists all of the articles published on a specific topic. I found absolutely zero hit on inherited marrow failures and transitioning of care. So when I was mentioning earlier that there is an unmet need in terms of the scientific and the knowledge and the way we should do, there's a good illustration here that we need to answer those questions more strictly and develop programs that really support this transition from pediatric to adult care. There are some articles that talks about transition of care for patients with complex disease. So somehow those articles are by proxy articles that can help us, get some ideas and inspiration of, how to organize transition. But definitely for patients with inherited marrow failures, we ought to do better. So how can we do this, and what can we do? What is already known in terms of transition of care from pediatric to adult healthcare for patients with complex care needs? This is an interesting article that was recently published from a Canadian group. And what they have done is they have reviewed almost 2,500 articles. Among them, they have selected 47 articles that they reviewed. They have chosen those articles based on the quality of the publications, the size of the patients that were trying to evaluate what is important for transition for youth with complex care needs. And what do we learn specifically from that articles? There are important things that could facilitate the transition. There are factors that represent barriers, and you certainly recognized them. You certainly know them. You probably have heard about them. What are the facilitators? It's clear that it's important just to ensure that your healthcare professionals have dedicated time and resources that could facilitate or help a young transition from one place to another, from one system to another. So there are at various places nurses or nurse coordinators that can help do this. Having this in place is something that might facilitate the transition from pediatric to adults. It's clear that if you have a support from a range of stakeholders, and it is important that we do have that conversation as today with AAMC, and again, thank you, Fiona, for the invitation. Having these continuous discussions with stakeholders, patients advocacy group, is something that also help to frame that process of transition. We need to get good partnership with hospitals leaders and ensure training of care providers on the importance to have adequate transition from pediatrics to adults. There are certainly barriers. It's not easy to get adequate funding to support a transition of care. Fortunately, looking over the past 5 years, there are increased recognition of the importance of the transition of care from pediatric to adults, and there are more and more places that start to get more funding put into the process of transitioning from pediatric to adults. There are still, however, a limited number of adult providers with appropriate trainer to provide care with the condition. And if we think of patients that have a chronic condition, not all patients do necessarily have symptoms. So patients with chronic conditions that are asymptomatic might be less concerned with the situation and might, neglect somehow the importance of a follow-up when they reach adulthood. There is also a lack of integration of educational social services that could represent a barrier. So how do we see the transition from pediatric to adult care? Actually, this is one of the things that is really important is that we should start to think this process early. For a long time, when patients were reaching a certain age, in Canada, it's usually 18 years old, patients are transitioned from the pediatric place to an adult facility. If you do this quite abruptly, that represents a risk of a breach of continuity of care. So one of the things that we certainly have seen, not only for patients with inherited marrow failures, but for various types of chronic condition, is that you need to initiate the discussion on transition early on. And ideally, we try to start the discussions around adolescence when patients reach 12 to 14 years old. And one of the things is that we need to see this as a continuity of a continuous discussion, right? First, start to discuss on what does it represent to transition from pediatric to adult care? Do you have a policy? How can you help patients to get prepared to transition? Have a continuous discussion and track progresses of the young patients to see how they can project themselves into an adult world and get prepared as much as possible. And when I say, with the patient, it's clear that this is a reflection that needs to take place with the entire family. But what we're trying to do is just to ensure that the patient start to have good knowledge on his or her disease, knows the medication they need to take, and start to get more involved with their care. What we try to do on the medical side is just to develop a plan, including a medical summary that could goes with the patient into the adult facility. So definitely this is an active process, and there are several things that can help this process. If you have a worker that has dedicated time to have this process, to plan ahead, again, as I was saying, this process of transition, try to get support, and not only tell the patients, okay, now you go to the adult facility and good luck with that. So you need really to have this ongoing discussion with the patient, with the adolescents and their family, just to ensure that we covered all of the bases. What we try to understand, and what we continue to try to understand, is what is actually in place or not in place across Canada. So what I'm going to show you is preliminary results of the survey that we've done with pediatric sites, just to know if what was in place at each center for patients with inherited Marrow failures, how each center was approaching the transition. So we sent the survey to 60 individuals who were identified as C17 workforce as practicing hematology. C17 is a national group regrouping the 17 pediatric hematology oncology institutions across Canada. And we sent this through our web-based system that is called Cecido. We received 33 responses, 29 of them were completed. And among them, what we can observe is that the patients that responded, actually, a majority of them were seeing patients with Marrow failure conditions. We had 27 responses from Canadian side. I suspect that one provider might have been a fellow that moved to Switzerland. It's not me. So we had one response from an international site. We analyzed the different answers. So this is the 17 sites. We just, anonymized all the centers because the point is not to compare answers from one center to another, but just to get an idea of, among different centers, the number of respondents per center. So we had usually between 1 and 4 responders by centers, which is certainly an surrogate markers of the size of the centers. All centers saw patients under 18 years old. So the age of transfer, as it is most often in Canada, was 18 years old. If we think of the number of patients with bone marrow failures that were followed by centers, we see that sometimes centers were seeing less than 10 patients. 4 of them were seeing between 11 and 20 patients. When I say centers, it's providers. 6 providers were seeing more than 20, and we had 2 uncertain numbers. We were interested to see who among providers were primarily following patients with bone marrow failures. In some centers, there was a core group of MDs. At some other centers, all hematologists were seeing patients with bone marrow failures, while in some other centers, all pediatric hematology and oncology physicians were seeing patients with bone marrow failures. We then asked each individual to report the number of patients with bone marrow failures that they individually followed. The average was 23 patients with a median of 11 patients. And we had a minimum of 5 patients were seen by providers with a maximum of 165. I suspect this represents certainly one of the largest centers in Canada. We wanted to know at each place where the adult, if there was an adult, when the patients reach adulthood, who would they follow and to who they were referred. So we tried to distinct if the patient has had a hematopoietic stem cell transplantation or if they had a stem cell transplantation. If they didn't have a hematopoietic stem cell transplantation, patients were usually referred to an adult hematologist. If they had a hematopoietic stem cell transplantation, they were also referred to an adult hematologist, but also in some occasions, patients were also referred to programs that was doing transplantations in adults or specialist physicians with has an interest and knowledge on late effects, which certainly makes sense because patients that have stem cell transplantations are at high risk to accumulate some of the long-term effects after stem cell transplantation. Among all the centers, 5 had regional adult bone marrow failure programs they were working with. And to see how well connected the centers, how well the centers were connected with an adult providers on a scale of 0 to 100, you see that the average and median score was 50. So certainly what we see is that we still need to make a lot of progress to organize the transition of care and to reinforce the quality of transition of care for patients with bone marrow failures. We had 4 centers that had a formal transition process. 2 of them reported that this process consisted of direct referral to an adult hematologist. One started preparing the patient to transition and about 2 years before before sending the patients to an adult facility, with providing a short description of the transition. And another was providing a new consultation on the disorder to the patients before the transition. 3 centers had transition criteria. We were interested to know, if centers had strict criteria to define the transition. And it's clear that the 2 main criteria that was observed is age over 18 years as expected and patients having a bone marrow failures. All centers generally transition patients when they reach 18 years of age. So, it's not a lot of information, but certainly what I take home from that quick survey is that patients with inherited marrow failures definitely need to have a more structured approach from transition of care. And that the transition of care remains, at least in Canada, overall quite ill-defined and variable across the country, probably with larger centers being having an approach that might be a little bit more structured, but still, overall we can say that we need to get to do better. While we see that some centers have established contact with adult providers, we see that 2/3 actually did not. So there is certainly a need to improve the contact between pediatric and adult centers with interest in marrow failures. And it's clear that this is particularly important for patients who have benefited from hematopoietic stem cell transplantations. Those patients may have a more structured transition, particularly if they're referred to physicians that have expertise in long-term effect. But certainly this type of approach could be an inspiration for all of our patients. What do we want to do next? It's clear that we need to continue to establish a good cartography of what do we know across Canada? What are the numbers of adult providers who would feel comfortable taking over the care of patients with inherited marrow failures, so that we know to whom we can refer the patients. And if we have that in place, it certainly can ease the transition at each centers and at each provinces. We would like also to regroup the existing and developing educational materials so that it could, enhance the education of patients with inherited marrow failures, particularly in adolescents and young adults. If we can, it's important that patients know their disease and know what they need to follow up. And that can certainly help the transition of care. We reinforce the importance of the transition of care along with the medical summary, which is something that I think we are all doing. And we certainly want to engage on increasing the awareness of inherited marrow failures in primary care providers. At each site, we want to encourage the use of tools to evaluate the preparation and readiness to transfer to adult care. And there are existing tools that can help and guide how ready a young is to transfer to adult. What do they know to do? What do they know in terms of their disease? I'll give you an example of what a track questionnaire is. And we really feel that it is crucial that we continue to engage all patients advocacy group to support this important and difficult process of transitioning. It is also crucial that patients and patients advocacy groups continue to voice the importance and the need to get good advocacy to support rare and orphan hematological diseases. And I really hope that you'll continue to help us advocate for this. So this is an example of the track questionnaire. And what do we discuss with the young? Well, those are very simple questions. If the young has to take medication, who fill a prescription if they need to? If they have a reaction, who do they turn to? Who do they discuss? How are they prepared to discuss this? Do they take their medications correctly, and do they take it on their own? Do they record medications? And do they initiate a reordering of the medication before they run out? Who is doing it? Is it the young, him or herself, or is it the family who usually takes this? Who is keeping record of the appointment? Who scheduled the appointment? How confident are they to do this? How do they track health issues, et cetera, et cetera? So, what we try to do in terms of preparing a young to transition into adult, it's important just to try to answer all of those questions, because that can help them to be more comfortable when they reach the adulthood and needs to face an appointment by themselves. And certainly, preparing the young through such question doesn't necessarily mean that when they reach 19 years old and they go to in an adult facility, that they will necessarily go alone. It is mostly to ensure that they are ready to go into that step. There are also other things that we want to do. First, we'd like to get, we'd love to get more data. Eagle Drawer is an outstanding scientific physician, has been active at SickKids for many, many years. He has started the inherited marrow failures. I think it is crucial that this registry is ongoing. The Canadian Inherited Marrow Failure Registry, held by Eagle, has helped us to foster a lot of important knowledge on the epidemiological, the epidemiology of inherited marrow failures across Canada, and improve the quality of knowledge of this disease. It helped us to find new, to discover new gene anomalies that were associated with certain types of inherited marrow failures, and participate in a good ground of knowledge. So it is crucial that we continue to improve this registry, ensuring that adult partners continue to collaborate with this registry. And this is crucial if we want to better understand the disease path and hopefully improve the quality of care and what we need to do to ensure and to limit disease complications. And again, as I said, is that we need to have a multidisciplinary, expert-guided on transition of care for patients with inherited marrow failures. We have to recognize that the recommendation of following up of care will differ if a patient has a Shwachman-Diamond syndrome, or if has a Fanconi anemia, or dyskeratosis congenita, or Diamond-Blackfan anemia. And so it is as well for patients with inherited neutropenia or inherited thrombocytopenia. All those types of disease are regrouped in inherited marrow failures, but it's clear that the specifics of following up care for all those diseases will vary. And this is an example, I'm sorry if that's a bit small, but this is an example of what we usually recommend at my place. For example, for patients with dyskeratosis congenita, the frequency of the hematological follow-up, the frequency of biochemistry follow-up. We recommend that those patients has a follow-up with ENT, with dermatology, with pneumology, because patients with dyskeratosis congenita can have lung complication that is really well known. It's not the same thing for patients with Fanconi anemia, right? It's clear that you're going to see some similarities in terms of following up for patients for hematological parameters and biochemistries. Dermatology is also important for those patients because they might have skin complications. Those patients may have urogenital complications, particularly true for women. And we need to make sure that they continue to have their regular follow-up in this regard. I'm sorry if it's getting smaller and smaller, but this is the last table. It is another example for patients with Shwachman-Diamond syndrome. Patients with Shwachman-Diamond syndromes have different disease complications, and they also need to get a good follow-up with gastroenterologist, dental follow-up, and lung specialists, because they might be more susceptible with lung infections, for example. So organizing the following up, again, as I was mentioning at the beginning, can be complex because you need to ensure that not only we, as hematologists, that we're ensuring the following up of care for hematological complications, as it is on a foreseen on the forefront of those diseases, but we certainly have to recognize that that this can be a multi-organ problems, and ensure that there is an adequate follow-up for this. So I'm going to stop there, and I hope I'll give you an idea of what we try to do. There's still a lot of work to do in terms of organizing the quality of the transition of care and then for patients with inherited marrow failures. And we'll continue to that work, particularly with Ingal Drawer. I really would like to thank Mira Ryer, Vicky Bricky, and Runa Sina, who have actively participated in the surveys. And we're trying to have a similar survey done in adult providers so that we have clearer pictures of what's going on across Canada. And really would like to thank Cindy and Fiona for the invitation. And I hope that we'll continue to get this important conversation with all of you. So I'd be happy to take any questions. Feel free.
Well, thank you for that presentation on a topic that is definitely more complicated than it seems at first glance. Once you get into it, I learned a lot from that. I'm just going to unmute the line, see if anybody has a question they would like to pose. Anybody there have a question? I have one for you, Dr. Pastore. We have on our website right now these sheets we call prompt sheets that list questions that patients might want to ask their doctor when they first get diagnosed. And I'm just wondering if it might be useful for us to have one for a patient who is transitioning to adult care, and some questions they might want to ask their doctor.
Right. I think transitioning from pediatric to adults, it's such a crucial time that I think to get a specific list of questions that adolescents might want to ask, the parents also might want to ask, would be very interesting. And you know what, as I showed you for the track questionnaire, is a tool that is being used for quite sometimes for various type of disease. It's used a lot for patients, for example, with cancer, when they are cured of their disease and need to transition into the adulthood. What they need to follow up. Do they know their past history, what medication they have taken, etc. It's important that they know this. So and there have been a lot of adaptation for this. For various types of disease. For example, there are an adaptation for patients with bleeding disorders or patients who takes anticoagulation to know if they know their medication, how frequently they're taking it, etc., etc. And I think that this is an adaptation of something that we could think of for patients with inherited marrow failures, right? So it is the part of preparation, but there are so many questions that we don't necessarily think of, when we're doing routine consultation, right? So to help list the thing that you want to ask is it certainly can be helpful.
Yeah. Okay. Well, I'll bring that up with Cindy, and maybe that's something we can work on.
Absolutely.
The track questionnaire you mentioned, is that just used in your center, or is it used?
Something that we use a lot. I know that many centers have used the track questionnaire or similar questionnaire.
Okay, good to know. And you had a slide which showed examples of what would go in a care plan. Is that something that you have templates for, or do you have, an information sheet that tells patients what they want to put in their care plan?
Right. That we do not have that. That we do not have that. Right. Okay.
Great. Okay.
But there are definitely a lot of tools that needs to be developed, right, and to help this transition of care.
Yeah, and AMAC's certainly interested in posting any of those as resources on our website if they are available. Yeah, great. Any other questions out there? Anybody want to type a question into the Q&A?
Silent group.
Okay, well, it looks like
I did not put them asleep.
Oh, I found it an interesting topic, and yeah, I think we could do, like I said, we could say more about this topic on our website as well to help patients and families. So thank you very much for sharing the current information and research with us. And thanks to the rest of you for joining the webinar today. I just want to remind you that we are still hosting online patient support groups. So if you are interested in those, please check our website for how you can register and join us on one of those Zoom calls. And we will also be launching a whole slate of webinars for the fall. So please keep an eye on our website for that too. Thank you very much, everyone. Have a good evening.
Thank you. Bye-bye.
Thank you. Bye-bye.